Vamos a presentar ahora a nuestro primer ponente, que es Michael Dilley. Michael Dilley viene desde Londres para estar con nosotros. Es experto en daño cerebral y recientemente ha sido nombrado jefe de servicio de Neuropsiquiatría y Neurorrehabilitación de The Wolfson St. George's Fundation Trust, ¿lo he dicho bien? Para el cuidado de pacientes hospitalizados con daño cerebral, con trastornos neuropsiquiátricos en general y con lesiones cerebrales. Anteriormente, el Dr. Dilley había sido responsable clínico de los servicios de neuropsiquiatría y jefe de servicio del Centro de Rehabilitación de Daño Cerebral de Blackheath y South London Maudsley Hospital. Asimismo, es miembro ejecutivo de la Facultad de Neuropsiquiatría del Royal College of Psychiatrists. Michael, por favor, cuando quieras.
Thank you very much. It's a real pleasure to be here. And I'm going to talk to you about something which really underlines this difficulty between the mind and the brain interface. So if we can have my slides. So I think it's important to start off by saying that neurology and psychiatry and neuropsychology aren't separate things. They need to work together. And even in the 21st century, sometimes I have to worry whether we do actually work together. And this is a quote from Adam Zeman and colleagues, which identifies that illnesses are psychological as well as physical. And whilst that might be a startling claim, on reflection, it's not all that controversial. Diseases don't come to doctors, patients do. And the processes by which patients detect and describe and ponder their symptoms are all very psychological. So the question as to whether all of our emotional experience, the mind, is all in the brain, from a neuropsychiatric perspective, is certainly the case because cognitive, emotional and behavioural involvement in neurological conditions is common. This paper by John Stone in the JNMP and his colleagues identifies that around about 50% of people that present to neurological clinics, specialist services, have underlying emotional, cognitive and behavioural problems alongside their neurological disability. And of course, psychological upset can present as neurological symptoms. So I spend a lot of my time helping people that present with what looks like neurological disease, but isn't explained by underlying brain damage or brain changes. And so this idea that the psychology can present in physical ways is absolutely critical to the mind-brain interface. And then neurological conditions cause psychological problems, and neurological conditions also manifest themselves in psychiatric disorder. And that's the very reason for having neuropsychiatrists and bringing the two disciplines of neurology and psychiatry together. Of course, as Adam Zeman's quote pointed out to us, patients don't come to us as diseases. People aren't a disease. They come with problems, with symptoms, with difficulties, which are impacted on by a huge range of other factors, not just biology. And whilst I totally agree with the sentiment of Ignacio's introduction, the importance of biological factors, of course, all of those things come in a social, cultural and psychological context. So here, for example, disease is one factor, but psychological factors, social, cultural factors and physiological processes all impact on the way that patients present their symptoms. Simon Wesley, who's my old boss at the Institute of Psychiatry at the Maudsley, some time ago now, pointed out that functional symptoms, so symptoms which aren't explained by underlying organic disease, present across all dimensions of medicine. So they're seen in every single department of medicine. And there's one argument that it depends on which doctor you see as to which label you get for your symptoms which are unexplained by disease. So if you happen to see a neurologist, you might be told that you have functional weakness or non-epileptic attacks. If you see a gastroenterologist, they might say that you have irritable bowel syndrome. But actually, when there's an inquiry with patients that present with symptoms unexplained by disease, you find that they share a huge overlap of symptoms across all of these domains and subspecialties of medicine. What I wanted to focus in on is what my specific interest is, which is in mild traumatic brain injury. And this is a really good archetype in terms of explaining the mind-body interface and starting to try to understand how, when there isn't anything perhaps on a brain scan, why a patient presents with a certain degree of disability, to try and tease apart at the interface between mind and brain. So I wanted to take you through a very common clinical scenario which I see in clinic nearly every week. So this is a story of a 38-year-old lady who is seeing the doctor, has a 6-month history of persistent headache. She has memory and concentration problems. She's irritable, she's fatigued, and she's sleepless. She's not been back to work, and her husband says that all of her difficulties started after a road traffic accident when her stationary car was just shunted from behind. And he was with her at the time. He was a passenger in the car. It was a stationary car. And he was sure that she only lost consciousness for a matter of seconds. And when I look at the accident and emergency, the emergency room notes, I find that her Glasgow Coma score, her GCS, which is a measure of a level of consciousness, was actually 15, which is the highest score that you can get there, 1 hour after the accident. And also a test of her orientation and cognition, the abbreviated mental test score, was also at the maximum score of 10. And her neurological exam and her neuroimaging were also normal. So this is somebody who's had an accident, continues to have persisting symptoms, and has normal investigations and normal tests and normal assessment from all perspectives. So how severe was that lady's head injury? That's the first question that we ask. We're trying to understand what injury severity is so we can see whether there's any relationship between the presentation of symptoms and the underlying neurological damage. And this is where we start to have problems, because a lot of the markers that we use to identify severity of brain damage are proxy biomarkers. They're not true biomarkers. They're things which are trying to establish what might happen after a head injury on the basis of findings which are seen contemporaneously with the injury. So I've already mentioned the Glasgow Coma score. That's one measure which is used to identify outcome after a head injury. It identifies neurological outcomes much better than neuropsychiatric outcomes. But the problem with it is it depends on who's measuring it, when they're measuring it, and unfortunately it also has what we call a ceiling effect. So as you start to get to the top of the scores, the same score doesn't mean the same thing for all of the people. So somebody with a GCS of 15 might not be the same as one of their peers who's also had a head injury who has a GCS of 15. So there's a real limitation to these kinds of assessments. The other thing that we use to measure severity is the duration of what we call the post-traumatic amnesia, which is the period of time from the injury until the patient regains day-to-day memory, or anterograde amnesia. And that's a much better indicator of neuropsychiatric outcome. And if it's longer than a month, as a rough rule, that has an impact on people's return to work and their vocational outcomes. But equally, there are problems with assessing post-traumatic amnesia. It's often done retrospectively. It's often done as an account from a patient who can't remember what happened to them, or from their relatives who are amazingly emotionally concerned at the time and might not remember some of that information. So there are a number of different problems. The second problem is that our definitions of these difficulties after head injury, traditionally in the UK, the word concussion has classically been used to describe the problems after a head injury of a relatively mild or minor severity. And there's a real problem with that. And my colleague Dave Sharp at Imperial, who's a neurologist, has put forward the idea that we should really get very tight on our definitions of the outcomes after brain injury, and that we should be calling concussion mild traumatic brain injury, or MTBI. Now, I have some problems with that because the patients that I see in clinic come with no evidence of brain damage, but significant symptoms which might not actually match what you're seeing on a scan. Dave's argument would be that there's some unseen damage at a neuronal level which isn't seen on scans, but there's a limit to how much you can see. And of course, imaging technology now is able to show us where there are microhemorrhages. So using certain types of MRI techniques, you're able to identify where there have been small bleeds around axons. But that's not always the case. And trying to get this match up, the congruence between this presentation of symptoms and the underlying brain damage, is absolutely critical. I don't think, unfortunately, that DSM-5 helps us very much. What it's done is polarize the outcomes after head injury into the very neurological or the very psychiatric. And I spend my entire life, and I've spent my entire career saying it's not just neurology or psychiatry, it's nearly always both. So trying to find the middle position, that area of neuropsychiatry where there's an overlap between the two, is critical. And DSM-5 doesn't help us with that at all. It's seeking to say it's either neurological or it's psychiatric. The problem with many of the definitions is that they don't identify the same diagnosis even in the same population. So there have been lots of studies that have been done with the old ICD-10 and DSM-4 criteria to look at whether there are agreements between those diagnostic criteria in identifying the same group of patients with post-concussion symptoms. They don't. There's only a 40% agreement between the diagnostic criteria. But the interesting thing is that there are actually very few differences in the symptoms that patients present with, irrespective of those diagnostic criteria. The other difficulty is that the kinds of symptoms that you see after a mild head injury aren't just seen after mild head injury. They're pretty common in the general population, but they're also seen in other people who've had trauma. So this study by Mears and colleagues was trying to identify whether post-concussion symptoms were specific to people that had had head injury. And what they did was use trauma controls to try and identify whether those trauma controls had similar symptoms, and sure enough, they did. So those symptoms aren't specific to head injury. You can just break a bone and still present with those symptoms 5 days later. So there's something about the experience of trauma. And many of those symptoms are very similar to things that we see in other medically unexplained syndromes like chronic fatigue syndrome or somatization disorder, somatic symptoms disorder in DSM-5. So symptoms are present even in people that haven't had an intracranial injury. They're very common in the general population. And having a head injury in itself doesn't necessarily predict that you're going to develop post-concussion syndrome a week after injury. When you ask patients whether they've had a concussion, so this was a study that was done by McKinley and colleagues in the emergency department waiting room, where they asked patients whether they'd experienced a concussion. And 59% of the people that they surveyed said that they had had concussion. And then later on, they were asked whether they'd had a head injury. And interestingly, of those 59%, none of them had had a head injury. So something in the label to the patient which carries a different meaning altogether. So patients are saying, I've had a concussion, doctor, but I haven't had a head injury. So what does this word concussion mean? And I think this starts to unravel some of the importance of the labels that we use. So concussion in itself has been suggested to be a rather softer term than brain injury. And this study, which was done in the paediatric emergency department, was looking at the impact of the label that the patients were given. In fact, the parents of these children were given after a head injury. And those patients who had been told, or those parents that had been told that their children had had a brain injury, the children did much worse in terms of outcome and return to school than those parents whose children were told that they'd had a concussion. So there's something about the label which carries meaning to people and affects outcome. So I'm just going to take you through what we usually expect to happen after a brain injury. And just to start off with, much of the cognitive outcomes data, which looked at how people do cognitively in terms of recovery, comes from sportsmen, athletes, and a lot of this in North America is from football players. And in football players, where you're using a paced auditory serial addition test, which is a working memory test, to see whether there's a recovery of cognitive function after a head injury, what you see is that in comparison to controls, the players return to their baseline function at around about 5 days. So when people are motivated to return back to the field, as athletes are, they want to get back on with the game, the duration of cognitive impairment is around about 5 days. But in terms of the general population of people, these aren't athletes. There have been a number of meta-analyses looking at recovery, and the most recent one is Marty Rowling's study from 2011, which looked at 25 studies, And they did this by looking at what we call epochs of recovery. So they were using specific time periods to see whether people had recovered to their cognitive baselines. And essentially what they found was that in the first 7 days, there was a large effect size of head injury on cognitive recovery, but by around about 3 months, there's a very little to no effect of head injury on cognitive recovery. So in the general population over these 25 studies, the suggestion is that the vast majority of people recover back to their cognitive baseline by 3 months. But having said that, and this is a study done by my predecessor, Robin Jacobson, around about 20% of people persist in having symptoms way beyond 3 months to a year for way longer. And that 20% of people have been nicknamed or termed by Ron Ruff, who's a neuropsychologist in North America, as the miserable minority. So they're people that persist in having symptoms, who are really miserable and unhappy and have really significant impact on their lives of their symptoms after head injury, which isn't explained by the underlying degree of neurological damage. So, what sorts of things can affect how this plays out, and what sort of things can affect prognosis? So this study by Hu and colleagues was looking at the impact of people's expectations and illness perception on their outcomes. And what they found was that illness perception had a significant impact on outcome at 6 months. This was a prospective study looking at what people thought was going to happen after their head injury, and using illness perception questionnaires, and then looking again at 3 months and 6 months as to what had happened to them. And if they have a negative or pessimistic perception of what is going to happen, they do much worse in terms of their outcome later on. And so John Silver in North America again has started to bring some of these other factors together in a paper from 2012 in the Journal of Neurology, Neurosurgery and Psychiatry. And optimism has been identified as a really protective factor for how people do in terms of their outcomes. So if you're optimistic about how you're going to do, you do better. And illness belief also has an impact on the duration of your symptoms and how severe they are. And if you really identify with having had a brain injury, and that becomes part of your kind of self-perception, that also has an impact on how you're going to do. When we're neuropsychologically assessing patients after head injury, so using cognitive testing to establish what their cognitive function is, we often, as clinicians, jump to conclusions about how much effort a patient is putting into the tests. So we use tests to actually establish whether there is optimal effort being applied to the tests so that you're able to more understand what other factors might be impacting on the findings of those tests. And we assume when people fail tests of effort that there's some kind of conscious, the automatic assumption is there's a conscious process that's going on, that the patient is making a specific attempt to fail the test. And what I wanted to point out here is that actually patients often will be putting in extra effort in tests. It's not that they're underperforming, they're actually trying to do the test to the best of their ability. They're trying to do it perfectly, and therefore in time tests are taking much longer to do something than you would expect because they're trying to do it really, really well. So the kind of assumption that the patient isn't putting in effort might not always be the case. It might be that they're actually trying to put too much effort into something and subsequently performing badly. And there are these two other factors here. These are all psychosocial biases that I'm talking about now. Stress affects all of our performance. So you'll all be aware that when you put extra effort into getting that hole in one or getting the match point in a game of tennis, you're much more likely to make errors when you're over-focusing on your performance. And that's what athletes describe. You know, when you're really under stress and you're trying to get the point or you're trying to do really well at something. Or the other example is if you're trying to remember something, the harder you try to remember it, the less likely you are able to. As soon as you distract yourself and don't think about it, it comes straight to your mind. So there's some kind of idea that if you put people under stress and they over-focus on the outcome and their performance, they do much more badly, and that's something that we call stress threat. But there's also this idea of stereotype threat. So a lot of the labels that we give to people carry with them inferences about how they should behave. So, again, in the North American literature, when you give African Americans tests to establish their mathematical ability, because there is the pejorative sense that people from an African American heritage might not be so intelligent, people perform badly in doing mathematical tests because that is the sociocultural expectation of how they perform. Similarly, if you give Caucasian men tests of their athletic ability, they do badly because the expectation is that Caucasian men are amazing athletes. And so these kinds of things have an impact on how people perform. In the context of mild traumatic brain injury, stereotype threat is really important. So this is a really interesting area. I hope I've got the translation right. I was going to ask David before I did it, that we have soap operas in the UK. I think you have soap operas here as well. And people pick up information from things that they see on television about how people with a certain kind of illness behave. Okay? So there's a sense of what epilepsy looks like. There's a sense of what somebody with dementia might look like. People pick up information from paradigms and archetypes that are presented to us within the media. And people adopt that bias that they will have certain difficulties in cognitive tasks or will experience certain symptoms when given a threat condition. So when, in this study by Sir and colleagues, medical undergraduates who'd had a head injury were asked to take part in a study which was called Working Memory in Young Adults Who Have Experienced Head Injury, they do much more badly than they do when they're asked to take part in a study of working memory in young adults. So as soon as you put the phrase have experienced head injury, people that have experienced head injury do much more poorly in their performance in those tests than when you take out that part of the title. Of course, a lot of head injury presentations come alongside seeking personal injury compensation. So many of my patients are enduring a long, often 7 to 8 year experience of trying to get compensation for their injuries. And this is really important because litigation, and any of you have been involved in litigation, it's pretty nasty. It's really stressful. It has an impact on how you feel, how you perform emotionally, how you perform in terms of your function. And actually, most of my patients never really get an apology from somebody. They don't get an apology from an insurance company. Nobody wheels themselves out and says, I'm really sorry, this was a really bad thing that happened to you. That very rarely happens. It's a protracted period of time going through court, fighting, seeing lots and lots of experts, people saying what's wrong with you, what's not wrong with you, questioning your symptoms. And actually, what has been found in the literature, again, is that the simple act of saying sorry to somebody when something bad has happened to them mitigates this need for revenge. So that if somebody says sorry to you, you're less likely to want to take up a complaint with them. And that's something in the UK which has just been brought into medical practice by our General Medical Council, is that we have this duty of candour or transparency, that if we do something wrong to a patient, you say sorry straight away, and it decreases the number of complaints against doctors. It's quite a straightforward thing. I quite like, if somebody's done something bad to me, I want them to say sorry straight away and acknowledge it. Another factor is in terms of something that we call loss aversion. So we're all much more averse to losing than attracted to gaining the same amount. So in general, in studies, you need to win €2 to offset a loss of €1. And the big question here in terms of compensation in mild traumatic brain injury is, what is it worth? What value do you need to offset the disability which has been caused by a head injury? And that in itself may increase symptom reporting in the context of compensation. And finally, in terms of social biases and social factors, unfortunately, we all cheat. So everybody does, just a little bit. Everyone will, if there's an opportunity, you'll take a little bit more breakfast in the morning, or you'll take a little bit more off the salad bar, or you'll take your chance, you'll do it a little bit. But the vast majority of us only do it a little bit. But there's a small number of people, just a small percentage of people, who do it a hell of a lot. And that is played out in the media all of the time with some of the scams, financial scams that happen. You don't hear about them every day, but every now and again when you do hear about them, it's this massive scheme that's happened where somebody's got a pyramid scheme and has made thousands and millions of dollars. There are a small percentage of people that cheat massively. The vast majority of us just cheat a tiny little bit and don't push it too far. So, what other factors can complicate recovery after MTBI? Increased age at the time of injury, irrespective of how severe the injury is. Having a mental health problem before your head injury also impacts on your outcome. And cumulative or repetitive injuries are thought to increase severity of your symptoms and outcomes. But I think I wanted to highlight in particular the impact of depression on symptom reporting after mild traumatic brain injury. So this study by Lang and colleagues and Iverson's group sought to look at the impact of mood disorder on symptom reporting in patients with head injury. And the left-hand bar shows healthy controls who hardly report any symptoms. The second bar shows people who have had head injury, mild traumatic brain injury, but aren't depressed, who report some symptoms, but nowhere near as many as their depressed counterparts, so people that just have depression. But the group that report the most symptoms are the patients that have MTBI and are depressed. So depression in itself mediates people's experience of symptoms and the likelihood of them reporting those symptoms after MTBI. So just coming to the end now, so starting to think about actually whether there are opportunities in terms of neuroimaging technology to differentiate between the neurological, the psychiatric, the psychological. And one of the magnetic resonance techniques that is being used is this technique called diffusion tensor imaging, which looks at the movement of water along white matter tracks and therefore identifies where there are breaks in connectivity in white matter tracks. And this study by Panek's group, just from a couple of years ago, is one of the first to investigate the relationship between white matter tract damage, depression, and head injury. And it was looking at people that had head injury 6 to 12 months after their injury and comparing them with people that had depression alone, as well as a control group. And what they found was that the patients with head injury that developed depression had changes in the diffusivity in areas of the brain, including the dorsolateral prefrontal cortex, corpus callosum, and nucleus accumbens white matter tracts, in comparison to those patients with head injury who didn't develop depression. And interestingly, those are the brain areas which are also found in depression alone without brain injury, which are impacted on in terms of diffusivity in DTI studies of mood disorder. And the relationship between reduced diffusivity was strongly correlated with the severity of depression on a depression measure. So the more severe your depression, the more reduced the diffusivity along white matter tracts. So there seems to be a relationship between depression severity and brain injury and white matter integrity. And this hypothesis that there might be a relationship between underlying inflammation in white matter tracts is an attractive one. So there's lots of talk about inflammation as being an underlying cause of mood disorder. And so it's not much of a jump to suggest that if people have had damage to axons and inflammation in white matter tracts, that makes them more susceptible after brain injuries to developing depression. And so there's a potential there as well for an intervention in terms of decreasing inflammation. But that's just right at the beginning of being investigated. The second study, which is just 6 months old, it's one of the largest neuroimaging studies in this context that I've seen. In fact, it's one of the largest neuroimaging studies, functional neuroimaging studies that I've ever seen. It's got a huge cohort. Again, it's a North American retrospective study across several centres utilising S.XX imaging and looking at two groups. One group of people that came from a neuropsychiatric centre, who are very, very well-defined group of people with brain injury, post-traumatic stress disorder, or both post-traumatic stress disorder and traumatic brain injury, MTBI. And they're matched to healthy controls. And then the second group, which is just over 11,000 patients, are unmatched, and they have all manner of different mental disorders, psychiatric illness, as well as traumatic brain injury, post-traumatic stress disorder, or both. And what they did was to look at different regions of interest from both visual readings and try to identify whether there was any relationship between those regions of interest and the diagnostic presentations. And these are the results. So if you look at the second row of images, the white areas represent the top 8% of cerebral blood flow. So they're the areas which are most perfused in these scans. And what we find is that controls have normal higher perfusion to the cerebellum, so posteriorly. In that first image at the bottom left, it's most white posteriorly in the cerebellum. Those people with post-traumatic stress disorder actually show increased perfusion into limbic areas, so areas such as cingulate, basal ganglia, insular thalamus, and prefrontal perfusion is increased as well. Those patients that have head injury alone have hypoperfusion, decreased perfusion of areas, as you can see on the third brain slide along. There's very little white. And then those people that have both conditions, head injury and post-traumatic stress disorder, you see something which is halfway between the two. And so the suggestion from the authors was that this might be a means to underpin the biology of these presentations and to perhaps try and differentiate people that have post-traumatic stress disorder from people that have mild traumatic brain injury. But of course, all of the factors that I've just taken you through are things which are going to confound that, and it might not just be a straightforward biological answer. So that was the end of my talk. Hopefully I've taken you through not only some biology, but largely some psychosocial and cultural impact on what is a very common problem, MTBI, and hopefully that also sets us up for a day of thinking about the interface between mind and brain. Thank you very much.